Thank you for joining us today. We are talking about obstructive sleep apnea or OSA, and we have Dr. Sue Rene and Dr. William Kristanto.
Yes, hi, I'm Sue Rene. You can call me Dr. Soon. I'm practicing as an ENT surgeon in Farrer Park Hospital, and my clinic is adult child ENT.
Hi, good afternoon. My name is William Kristanto. So I'm a cardiologist, and thank you for having us on board today to talk about OSA and its complications and how we can diagnose and treat it.
Yes, so obstructive sleep apnea is a very common problem in Singapore, and the prevalence is about 30% of our population. It's generally characterized as a complete or incomplete upper airway collapse. And what happens is that it actually decreases oxygen delivery to your body.
So, Dr. Sun, how do you diagnose OSA and how do you measure the severity of each OSA case that you see?
So normally when we see patients, the patient will come forward with complaints such as having loud snoring. The bedtime partner may be worried that the patient itself is not breathing well. What we consider such as like choking episodes, witness apneas, and literally not breathing when you're sleeping. The patient can have actually daytime symptoms as well, such as unrefreshed sleep, having headaches, memory losses, and even poor concentration at work, and leading to poor driving, increased accidents during his drives in the day, and poor work performance. So we have patients coming forward to my clinic and William's clinic quite commonly for such problems, telling us how can we manage it. So how do we go above all these symptoms and complaints then, and how do we examine the patient? So for ENT-wise, normally we do an upper airway examination, head and neck examination. We'll look into the noses, the throat, because common causes of obstructive sleep apnea is basically divided into anatomical and non-anatomical causes. So anatomical causes generally can be things very commonly such as having rhinitis with blocked noses due to swollen turbinates, is a lining in the nose. Or in a younger population, big adenoids or tonsils. These are actually reactive lymphoid tissues that actually block up the back of the nose and the back of the throat, and in general, narrowing your upper airway column of air when you inspire. So in the older population, we have things coming in such as aging, obesity, having a poor, what we call Friedman tongue position, a big tongue, a low-lying palate, a very thick neck, or even running in a genetics, in a family, diabetes and all that. And this normally predisposes to sleep apnea. So in ENT, normally we have a nasoscope that we can do in bedside. We would do what we call a awake nasoscopy to check into the whole upper airway to see whether things are reversible or not, such as clearing up the nose, giving some nasal sprays, washes, antihistamines, or even gargles to decrease the mucus in the nose, and clearing up the upper airway, teaching patients how to breathe through their noses, closing their mouths, decreasing the snoring sound, and eventually telling them if they do need an objective sleep test. So the diagnosis of sleep apnea, besides a good history and physical examination, would encompass doing a sleep test. And a sleep test, there are basically a few types, but the one generally which is more convenient would be a home sleep test, which I advocate as well. Would be sleeping in a natural environment. This is what I would like to test my patients in. It's very convenient. What we call a watch pad test. It's taking in place a good night, for example, no partying, no caffeine, no alcohol, sedatives or hypnotics, lying on your own bed, in your own pillow, and having a good night's rest. Basically, it measures what we call it apnea and hypopnea index. It means generally how many times your upper airway is actually collapsing completely or incompletely to affect oxygenation. Classically, more than 4%, your oxygen will drop and cause what we call an oxidative stress in the body. And this is why we would want to treat sleep apnea. And this is why sleep apnea is important and differentiates it from just being a pure primary snorer.
Is it something that you see in older patients or like something that you can actually have when you are much younger?
OSA can happen in all ages. So I see patients with OSA from young to the old. In young patients, firstly, I think you need to classify young patients to patients who are syndromic or non-syndromic or with congenital problems or or normal children. So they have a very different cause of what is a causative factor of sleep apnea. And generally, unfortunately, in males, as you progress in age, the males aging population, those with obesity or more comorbidities, or it runs in the family, would be more predisposed to having sleep apnea.
Why do you think that's the case?
It's been studied that the Asian males do have more truncal fat. So this fat distribution is actually more in the midline. For example, in the upper airway, tongue fat distribution, in the neck circumference, and also, so sorry to say you have a tummy, truncal obesity. This normally, it's more, it's a body habitus that most sleep apnea patients have.
Okay, so would you say that it correlates to your weight?
Yes, actually weight and obesity, is almost a risk factor, almost directly linked to having sleep apnea.
That's a good point. So would you say that if I'm obese and I lose weight, will that actually eradicate all my OSA issues?
It generally helps improve, but it may or may not eradicate to normal AHI values.
Let's hear from the cardiovascular side. Why do you think there's this very distinct correlation between OSA and cardiovascular disease?
That's a very good question. So basically, when you have upper airway obstruction during your sleep, you have a decrease in oxygenation of your blood. And when that happens, when you're sleeping, the body is actually sensing that you do not have enough oxygenation to your vital organs. And so they'll send a stressful response to try to wake you up. But if you're in deep sleep, the body will have great difficulty in trying to get you to rouse, to try to get more oxygenation. During the nighttime, when you are supposed to be recharging your body, supposed to be resting, your body is actually struggling to get more oxygen to the body, to your vital organs. This results in the secretions of certain chemicals and hormones like adrenaline to try to wake you up or at least change your posture so that it improves the oxygenation to your organs. So just imagine, so Dr. Sun spoke about apneic hypoxic index. Now, this number means actually the number of times you're being strangled when you're sleeping, essentially what OSA is about. When you're sleeping, you're supposed to be getting a good rest, getting oxygenation to your body. But what's happening is that due to the fats around your neck or your tongue or your posture or your anatomical structure, you're actually being strangled. And the number of times you get strangled worsens your degree of OSA. So I have a patient who's have a relatively short neck. His BMI is 40. He drinks a lot of alcohol and he has very bad nasal polyps. So his upper airway is already obstructed. Oh, and to top this off, he doesn't have enough sleep. So his quantity of sleep is low and his qualities of sleep is poor. This gentleman had an apneic hypoxic index of more than 100. So he is being strangled more than 100 times in an hour in the 4 hours that he's sleeping. So you can imagine the amount of stress that the body undertakes. What then happens? So when he's sleeping, the brain tries to wake the person up by secreting adrenaline, and that causes hypertension. So when you have high blood pressure during your sleep, that then causes cardiovascular complications like coronary artery disease and even changes to your heart muscles that then leads to irregular heartbeat called atrial fibrillation that over time predispose you to the risk of having strokes. So most times when I review my patients and I notice that there's a history of hypertension, I actually delve deeper into their sleeping habits. So as what Dr. Sun does, I'll actually ask the sleeping partner whether they notice that their partners are being choked. So normally they will complain that, my husband makes a lot of noise, he's snoring very loudly, and I notice that sometimes he stops breathing. So this is a visible apneic spell. So these are the alarm bells that tells you that, hey, this patient does have obstructive sleep apnea. And at this instance, I will then make an appointment to see Dr. Sun to get the diagnosis of OSA established so that he then can undergo certain therapy. And what's important is also that when you control the OSA with whatever methods like CPAP, it actually helps with the hypertension. So I do see patients who have a reduction in blood pressure pills just by controlling their sleep apnea. But more importantly, they actually report being happier, less grouchy, having better rest, and that leads to the patient feeling much better. Sometimes they can't articulate, but when they see you in after a month, they look more fresh. There's a change in their appearance, and they actually look more relieved and happier.
How dangerous is it to actually stop breathing when you sleep?
Basically, when you have all these apneic spells, you have increased blood pressure. So increased blood pressure is never good. It can cause heart attack. But I'm sure there's some cases where it is so severe that it can be even worse than that. So Dr. Soon, what's your experience with that in the literature?
There's evidence that with sleep apnea, especially the severe ones, without any treatment, it can lead to things like cardiac arrest, patients having heart attack and strokes. There is also an incidence whereby they actually do have sleep apnea. It's been brought upon with the family to investigate that as part of the cardiovascular investigations, but it was just left alone because, as William said, one of the management is actually on CPAP. It's actually what we call a positive airway pressure machine, and not everybody accepts this therapy and can wear it well every time when they sleep to increase the oxygenation. It actually functions as a mechanical splint that patients put on over their noses or over their faces to deliver an airway column, air pressure to keep the upper airway stented and open so that the upper airway doesn't collapse when they're breathing. So this helps stabilize the oxygenation overnight every time when they sleep and decreases oxidative stress and preventing all the cardiovascular complications that Dr. William has spoken about.
As an ENT surgeon, do you prescribe CPAP as a first line of treatment before you consider surgery, or do some people just choose to just go ahead and do surgery?
Okay, I think to answer this question, I always advocate that the treatment for sleep apnea is actually individualized. I think that's a very good term to describe it because I think you can't treat sleep apnea the same way in a child, a working adult, or in an elderly. However, most patients actually present very late with cardiovascular complications. So I think after having diagnosed sleep apnea, I think the main advocate for management would actually be the positive airway pressure machine, which is CPAP, which I advocate to all patients with sleep apnea because it is still the gold standard for having CPAP as a management to stabilize oxygen overnight. But of course, it needs to be worn with good compliance. What we call almost 80% of the time when you sleep. I even tell my patients when they take naps in the afternoon, they should put it on. However, a lot of patients actually in literature would say that there's a poor compliance take-up. For example, patients will look at the machine and they'll reject it straight away. They can't believe that they have to be hooked on this machine forever, every night. They'll tell me, is it temporary or is it permanent? And you can't imagine if you have a young family or if you yet to get married, to be traveling around, sleeping every night, lugging this machine around. So this are the group of patients that will ask me whether any ENT surgery can be done. These are the group of patients that I see mainly as well. So this is when the upper airway scope, the nasoscopy, can actually tell me whether there is any anatomical, structural abnormalities which I can remove, resect, stiffen to open up the airway. Again, it is subjective because I can tell you in general, in a normal, healthy adult with a good BMI index, for example, 23 and below, if you have very obvious upper airway obstruction due to like swollen turbinates, adenoids, tonsils, these are very good surgical candidates with very good results. I have cured patients in that category before. However, in the middle-aged patients, you have to be careful. For example, I actually don't advocate patients, for example, the patient group that William sees. So patients with hypertension, diabetes, lipid problems, obese, in the 50s, I normally don't operate on them. So surgery, in summary, is just, I would say, has good results in selected sleep apnea patients. What do you think, William?
Yeah, I think I echo your view. So I think treatment should be personalized to the individual patient. So in the younger age group, I think it tends to be more anatomical structure causing the obstruction, which can be removed surgically. But once you hit the 40s and 50s and 60s, this age group, I think it's more than just that. I think weight loss is one of the key things. We are having a lot of patients not being active enough. They're having very sedentary lifestyle, and that compounds the problem. So they have higher BMI, that leads to high blood pressure, poorly controlled diabetes, cholesterol. And so in that age group, we have to control their cardiovascular risk factors very closely. And we also have to improve their sleep.
But what if I don't want to use a CPAP machine? That would be still first line of treatment, right?
It's not uncommon for a patient to reject CPAP. I have some CPAP machines and models in my clinic. And upon looking at it, most patients say they don't want it. So what I can tell these patients is that a lot of these vendors that sell sleep machines, they have actually a trial. Don't dismiss it. Just try it. Choose a good trial period whereby you're not traveling, you're not disturbed by any heavy work commitments or family commitments to try it on and see whether it actually works. But if not, then it comes to the majority of patients with sleep apnea. I would say 70% of them. They would ask me, can I leave it alone? Will I die in my sleep? Is there no surgery that we can do? And I can tell them that, of course, we can operate on almost every patient. But you need to remember that we are operating on normal structures. So it is to stiffen, to widen, to improve your tensor muscles, to open up the airway when you inspire. And that's why it leads us to the latest development in sleep apnea, which is called a hypoglossal nerve stimulator. It's actually a tongue device that actually retracts and contracts your tongue muscles and open up your airway column when you inspire. That treatment, it's the latest advancement in sleep apnea surgery, but again, it's invasive and we have to do it in selected patients. To leave it alone, again, I would say it's quite common. Okay, you have to be careful of your health. Then we can go on to the other options of treating sleep apnea, such as lifestyle. You need to have good sleep hygiene, a good 6 to 7 hours of sleep in an adult, good sleeping habits, decrease stress, workout in the day. Generally, sleep improves. And of course, with our Asian diet, I have a lot of patients with reflux, sensitive noses is common as well. All this need to be treated. So if there's no management, I'll normally tell my patients to look at your own lifestyle and reflect what has been causing you to have sleep problems. Observe it for a while, monitor it for a while. If you feel better, you can leave it alone. But if you feel worse, definitely we need to work on it.
Actually, I echo what Dr. Sun has said. There's no magic pill for everything. It's treating everything, you know. So even you use CPAP or don't use CPAP, you still have to manage your lifestyle. Even myself, mea culpa, I have not enough sleep, not enough quality sleep. So imagine we are talking about the quality of sleep and the quantity of sleep. We don't get enough quantity of sleep. And now our quality of sleep is affected, right? And we don't have enough exercise. And so everything adds up. And that adds a toll to the eventuality, which is cardiovascular complications. So when my patients come back from Dr. Sun's clinic and they tell me, hey, I don't want to use the CPAP, look funny, then I think first we have to also explore the ideas, concerns, expectations. And as what Dr. Sun said, I think now the technology has improved so much. There are different vendors with different sizes for different mask fittings. So I remember when I was much younger, there was only 1 or 2 vendors and it was this like scuba diving mask and it was really quite...
It's like a Darth Vader mask.
No, there was a triangle one. There's this like the Catalan scuba diver, the whole face mask that looks quite... It's very painful because it presses against your whole face. So I remember my early patients literally don't want to use that. But now I see a whole, even I think there's customized masks to suit your different jawlines and nose. So I think first you must, as physicians, we must spend time to explore the ideas, concerns, expectations and tell them that, hey, actually, this is something that we can overcome or we can try to work around to see what really suits you. And so compliance is very important. So I'm very impressed with the latest breakthrough of this hypoglossal nerve stimulator. I've read and heard about it. It's very exciting that we now have more tools in our alma mater to help to combat this sleep quality problem. Yeah, but don't forget the basics. We need good sleep quantity as well. So I can't help but advocate for that.
Yeah, so none of us have enough sleep as it is, right? And we don't have OSA, or at least we don't know yet. Which brings me to this question. Okay, with this obvious link, right? How many % of patients with OSA actually go on to develop cardiovascular issues? Do you have any numbers?
It's quite difficult because I think the main challenge in this OSA problem, at least in Singapore, is the lack of awareness. So there's very poor patient understanding. Patients don't think it's a problem. Patient doesn't know that problem exists. They think snoring is normal because you're too tired. They think that this is an Angmo disease. Asians just don't have it. So there's a lot of misconceptions. They think that only fat people get it. So I have very skinny people with very bad severe OSA. And then we get, you're using a CPAP. Yes, I have very bad OSA. So there's a lack of awareness. And because of that, people don't really believe in it. And because of that, there's a lack of uptake of the treatment therapies like CPAP. So because of that, I think it's very difficult to prove causality. So where I'm at, I'm actually doing retrospective, means I'm seeing patients in their 50s, 60s who either had a mini stroke and then have atrial fibrillation. And then when I look at the body habitus, I say, hey, I suspect you have OSA. So for example, cardiovascular, we see a patient with like atrial fibrillation. We used to think that this was due to thyroid problems. And very few of us actually consider OSA as a cause of it. But nowadays, contemporary practice, we do consider OSA as a strong risk factor for atrial fibrillation. So on my part, I'm seeing more patients who already develop cardiovascular complications, and I'm just trying to do my best to correct the so-called lost years. So I guess it's very hard to answer your question. It's very hard to show that if you treat this early, it will not lead to cardiovascular complication. But this is part of it. And with the heart, everything adds up. Every small thing adds up. So you should do your best to try to curb whatever you can curb. Hypertension, cholesterol. So this smoking cessation, exercise to combat sedentary lifestyle. So this is one aspect that we forget or we do not think is important, called sleep. Quality and quantity of sleep.
I mean, back like 50 years ago, was that OSA, or there didn't seem that much focus or knowledge about this? Would you say that it is like something that has emerged over the last maybe 40 years, or people are more aware of this condition, or it's just been there all this while and you just think that you're very tired and just snoring?
I think the answer to this question is that I think the concept of OSA is still developing. More and more research has been going on to it. I think it is there. It's just that physicians don't know about it. And I think you can see in the education of doctors, sleep modules are coming up. We're educating the doctors. We're having public forums to the layman to tell them that snoring is just not a pure snoring sound. It can be more dangerous to the severity of having sleep apnea. So it has been there, and more literature, even what causes it. There's things like arousal index, neuromuscular laxity, ventilatory drive, looking at all these things, whether we can alter the response to having all these apneic desaturations. And how do we breathe, just to improve the airway column and to stabilize the oxygenation when we sleep, to prevent all these potential complications from sleep apnea.
I think the key message or the key words will be, to me, neglect and underestimation of risk. So I think we've always known it's there, but we tend to neglect our sleep. We don't think it's a big problem because we think we don't feel very severe consequences immediately. So it's something that just gradually builds up over the months, the years, and we just neglect. Our body's telling us we're very tired, but we just drink coffee and we just, sojourn through our work. And so we neglect the signs that our body's telling us. Maybe our partner's telling us that we're getting more grouchy, more irritable, we are getting high blood pressure, we are getting more stressed because we're not, working on everything. So we just neglect the warning signs. And then the other thing is underestimation of risk. So we know it's there. We heard that it's not very good, but we didn't think it was so bad. Like I didn't know that you can actually die from OSA if you really get choked and you go into a cardiac arrest. I mean, Dr. Soon has shared that it has been reported before. So even I didn't realize that you could have such bad severity of, which makes sense because you are really actually just getting strangled by your own body. And that's never a good thing. So I think throughout men's history, it's always been there. It's just something that there's more data and research on it showing the bad complications that come with it. It's just getting the general public or the lay person on the street to really understand the implications it has over time. Because sleep is something that we do every day. So we better do a good job at it to get our body to regenerate.
Any interesting patient cases that you can share?
The patient comes in with a partner and the patient itself doesn't think that he has a problem. But the partner is worried because she has seen the way he sleeps. He chokes. His body tosses around to find the best sleeping position because some of us have this thing called positional sleep apnea. And he's snoring very loudly and suddenly he becomes totally silent. And the partner would be worried whether he's choking himself to death or he has passed away. However, when I advocate things like wake nasoscopy, which is something a camera into your nose, going to a sleep test, and they look at a machine in my clinic and we talk about surgery, the patient will be shocked. Because he doesn't feel that it's a problem.
Yeah, actually, I share the same sentiments as Dr. Soon. So the patient doesn't think it's a problem. And he's wondering why everyone around him is making a big deal out of it, especially the wife. I say, yeah, of course you're snoring, she's not sleeping. But more than that, the wife is really, as what Dr. Sun said, so concerned that is he dead because he's not breathing for quite a long period of time. And I normally tell them to secretly video their partner sleeping to show and say, hey, look at the number of seconds you are not breathing. And this happens every night for X number of years. And can you imagine the detrimental effect to the body? So my experience with OSA is quite interesting. For those patients that I managed to get the diagnosis right and they end up seeing ENT, get a CPAP, they become a fully restored person. And I see the change. They tell me, yeah, doc, you're right. You're the only doctor that so far has told me I got this problem and you clinch the diagnosis now. I feel so much happier. Everywhere I go, I bring this CPAP along. I will not let it go. They are so addicted to it because they know that if they don't bring that along, they don't get good rest and then they become grouchy and they feel lousy. So I take joy in knowing that, yes, we manage, because it's very subtle. And these patients may not be fed. When I was studying in primary and secondary school in Singapore, I always fell asleep during lessons. The teacher thought that I had sleep apnea. I actually went to see an ENT and they said my adenoids were big. I wasn't really obese.
You were normal though?
What's normal?
What was the weight?
I was big on the big size, but yeah.
Okay.
So it was good so my wife is a pediatrician and she tells me that sometime in the assessment for children with learning disability, that actually sleep apnea is one of the differentials that the pediatricians actually think of. Meaning to say that the primary 4, primary 5-year-old child struggling in class, always sleeping, the teacher is always scolding the kid sleeping during Chinese lesson, could be a symptom of OSA. So right now, when we screen patients for OSA, we actually ask them signs, symptoms of like somnolence. So like after a meal, when they wait for the doctors in the clinic, do they fall asleep? And you'd be surprised, just a simple question like that can screen for OSA. So maybe I ask Dr. Sun, we have this stop bang question and all these things. How relevant is all this? Or, do you just...
Again, it serves as a guide. Yeah, it's a screening tool. For example, again, patients are waiting for me. I can get my nurse to just give it out to patients and see what is their risk factor, because all this are actually just a guide towards diagnosis on sleep tests.
I think it's the index of suspicion, right?
Yes,
that the patient
correct.
has OSA.
So after managing sleep apnea patients for a while, actually, if I sit with William in a hall or for coffee or something, you can actually tell who are the ones who has OSA.
Likely to OSA.
Who has likely has
how do
OSA.
you tell? You mean what?
You've seen enough patients, you roughly know that, okay, like...
So like an OSA phase? Or...
No, they're just tired, they're not fresh, and neck structure.
Yeah, so we have talked about the ones who are obese, overweight, but the petite ones, there's a thing called upper airway resistance. So for example, you have a very elongated face. You have, for example, the mid face or the chin being flatter, what we call hypoplasia, not developed properly, or having a receded chin or a short chin. What happens is that your framework of the face actually presses on or constricts. What I tell my patients is that imagine a basket. Your facial framework is a basket. And your fruits are your tonsils, your tongue, and everything. Okay, so if you have a smaller basket, which is a long, narrow face, petite face, but you have very juicy, fleshy fruits like big tonsils inside, obviously, it would be obstructed.
So it's a structural issue.
Yeah.
Yes, it's a proportion of your facial skeletal features versus the space against your soft tissue structures.
So it's like a house, but your furniture is too big.
Yes, that's
Yeah,
right.
it's obstructing the hallway. So the bigger the furniture, the less space you have to walk, and the less oxygen can enter.
When you look at somebody, you can actually kind of diagnose. So do I look like I have sleep apnea?
You look
Face.
quite okay.
I think you look quite okay.
I have some people coming to me, weightlifters. They do a lot of upper body. That's right. William, we can talk about it. I think you go to the gym, you can tell me.
No, I see a lot of them. I'm not. Yeah. They have very thick neck.
Okay.
Short and thick neck.
They do this chin, what's it called?
Chin up, pull up.
Yeah,
pull up.
chin up, pull up.
So-
they look very stocky.
Yeah.
So it actually decreases your theromental distance, your hyoid, basically the length of your neck, and the shorter your neck, the thicker the circumference, the more at risk you are.
It's a
for
structural
sleep apnea.
thing.
Oh, yeah.
It's not about
it
the
sounds
exercise
like-
they're doing. It's the structure of their airway. Yeah, so actually you're right. So Dr. Soon and I, if we sit down in the hallway, we can actually place bets as to who likely has moderate or severe OSA, especially after lunch.
Yeah, like drink if you see somebody you think has OSA.
It's actually very common. So remember, it's 1 in 3 Singaporeans are affected by it. It's just the lack of awareness and the lack of or neglect. They know, but they don't want to do anything about it, or just the underestimation of risk to the heart, really. And no one really talks about it. At dinner parties, we talk about our cholesterol, our number of stents that we put, our this surgery, but no one talks about, hey, my sleep is not good. So normally when they mention that, so like I always ask my patients, have you heard of OSA or CPAP? And if they say, yes, actually my friend has it, actually that actually breaks the ice, because then that's like a bit normal, and then they are more willing to accept it. So normally I just ask and explore whether they've heard of it. And those that are quite well informed will be saying, yeah, actually my don't know what, my boss has it, blah, blah, blah. And I've seen that machine. Doctor, what does it do? Then this is where you have the opportunity to then explain in greater details how it helps the sleep and eventually your heart. Because that's what matters, you see. The chronic damage to your heart, you want to prevent that.
So any last words or any takeaway advice you can give us with regards to OSA?
I think seek the help of a specialist if you feel that you have sleep apnea or symptoms suggestive of sleep apnea.
For me, don't neglect the signs. Sleep is important. Quality and quantity of sleep.